Welcome to Understanding Integrative Medicine Research. My name is Yumin Zhou. I'm a research scientist at UCLA Center for East-West Medicine. I'm a physiologist with a master in sports science, a PhD in Chinese medicine, a doctorate degree in nature medicine, and I've also practiced as a registered nurse. As a researcher, I've conducted clinical studies combining Western conventional medicine with Chinese herbal medicine treatment for tuberculosis, and have also conducted several studies utilizing National Health Insurance System data to evaluate the effects of combining conventional Western medicine with traditional Chinese medicine to treat depression as well as osteoarthritis. I will discuss special considerations in integrative medicine research in this talk.
I'm Emily Chang. I'm a geriatrician and internist at Harbor UCLA Medical Center. I completed the NRSA Health Services Research Fellowship at UCLA and also spent a year at the UCLA Center for East-West Medicine learning about traditional Chinese medicine and integrative medicine. During that year, I learned about many unique considerations that must be taken into account when conducting and interpreting research in this field in order to make sure that the conclusions are accurate. Through our discussion today, Dr. Cho and I hope that you'll gain a greater appreciation that there is research in integrative medicine and understand that there are increasingly better ways of doing it. We have no conflicts of interest to report. By the end of this lecture, you'll be able to 1. List 4 types of research questions. 2. Compare purposes of qualitative versus quantitative studies. 3. Describe 4 innovations in healthcare research design that have been successfully applied to integrative medicine. 4. List 3 reasons a randomized controlled trial may lead to a false negative result. And 5. Recognize the role of placebo effects in pain management. Let's start with an example based on one of my clinic patients and her daughter, who I'll call Miss Singh. Miss Singh just turned 50 years old this year. Her 80-year-old mother was recently diagnosed with dementia, and she wants to know what she can take to keep her mind sharp. I heard on the news that turmeric can help with Alzheimer's disease. Should I take extra supplements? Since she's South Asian, it's already part of her regular diet. How would you respond? So in the middle of a busy clinic day, we often turn to the internet or medical apps for information. But where should we start looking? If you're in an academic medical center, you might try a quick PubMed search. Unfortunately, as you can see in this case, we ended up with 780 results. Even if I told Ms. Singh that I would get back to her with an answer later in the week, most people would be lucky just to get through the abstracts, much less the methodology sections. Isn't there a more efficient way of getting an answer? You might have heard of the concept of different levels of evidence. The weakest type of evidence is anecdotes, as you can see on the left-hand side, such as, my mom told me that taking high-dose vitamin C can help prevent colds. A step up from anecdotes is expert opinion, which national guidelines are often based upon when there's few large trials conducted to answer the specific clinical question. The gold standard of research evidence has traditionally been the randomized controlled trial, also known as the RCT, where the intervention of interest is pitted against a control arm, which is often placebo, a passive intervention, or usual care. Participants are randomized to receive either the intervention or the control, and ideally both the participants and the researchers would be blinded to knowing which study arm a participant ended up in to avoid introducing bias. The goal is to find out whether the intervention of interest works better than the alternatives in a controlled environment where as many other variables as possible are removed from the equation through randomization or strict research protocols. Now, one RCT is just one RCT, and due to limitations of time and money, researchers often are limited in what they can accomplish in just one trial. So what if one RCT says that the intervention works and another one doesn't? One way of finding a more solid conclusion to a clinical question is to combine data from a bunch of different RCTs into a meta-analysis, using specific criteria to systematically find and screen studies for inclusion. So you can see this on the right-hand side of the figure. You may have heard of the Cochrane reviews, which are a major source of meta-analyses and are periodically updated. In the process, authors would check for bias towards only publishing positive studies and assess the overall level of quality of the included trials. It's hard to draw firm conclusions, though, if studies are dramatically different in types of participants or if there's a lot of variation in how the intervention was implemented. So authors must also assess for degree of heterogeneity in the data they're pulling together. Note that language may also be a barrier. Non-English language publications may get excluded if the authors are not fluent in other languages. So while meta-analyses are a great way to quickly get a snapshot of the current body of literature on a topic, they have a number of caveats and conclusions which may change with the addition of more studies. In addition to referring to review articles and meta-analyses, here are two other ways you can look up answers to clinical questions about integrative medicine. Because the body of evidence is still growing, be sure to check back periodically for the latest updates. Currently, much of the evidence-based medicine conversation about traditional Chinese medicine is still dominated by biomedical drug-type research, whereas integrative medicine is a much more complex intervention. Even supplements is complicated. What's the right dose? For what disease process? Are there specific patient factors that should be taken into consideration? As we'll discuss later on in this module, other research methods than the traditional RCT may be more appropriate for evaluating integrative medicine interventions. So you can see in the first bar, the National Center for Complementary and Integrative Health, or NCCIH for short. It's part of the NIH, or National Institutes of Health, and founded in 1999. Dr. Cho will explain more about the center in greater detail later in this talk. The website has a lot of information on different complementary modalities for both patients and medical providers. The second bar shows a project that the VA is doing. The VA has long invested in complementary modalities for veterans such as acupuncture and chiropractic services. In order to help promote faster implementation in areas with strong evidence, the VA recently started creating evidence maps for major complementary modalities, which provide information at a glance on the extent and distribution of current evidence on clinical topics as well as gaps in knowledge.
Dr. Zhang reviews some ways that you can find evidence quickly for different complementary modalities used in integrative medicine. Next, I would like to introduce you to the types of research questions that we are interested in. Integrative medicine research studies the cooperation of complementary modalities with biomedicine as a cooperative and integral part of the healthcare system. By integration, we share responsibility for management of the patient, share practice guidelines, and share common values and goals to treat the well-being of the whole person. NCCIH supports research on complementary and integrative health interventions across the continuum, from basic and mechanistic studies, how does it work, and all the way to efficacy, effectiveness, or programmatic trials. What are the specific effects? How well does it work in the real world? Here is NCCIH's strategy plan for 2016 to 2021. As you can see, it's focusing on two major areas, nature products and mind and body practice. Nature products include a large and diverse group of substances from a variety of sources, such as herbal, botanicals, dietary supplements, and probiotics. You will learn more about herbs and supplements in a separate module later in this course. Mind and body research includes a wide variety of interventions that are based in physical procedures or techniques administered or taught to others by a trained practitioner, such as acupuncture, massage, meditation, deep breathing exercise, hypnotherapy, qigong, and tai chi. There is a lot of interest in researching the effects of these interventions on pain, stress, anxiety, and other symptoms, and whether patients can implement these techniques in their daily life. Now let's discuss some special considerations that make integrative medicine research different from clinical trials for prescription drugs or medical devices. Clinical investigations of complementary modalities are made difficult by factors such as use of complex and individualized treatments, lack of standardization of herbal medicines, and identifying appropriate placebo interventions. There may be logistical problems in acquiring, randomizing, and retain patients. As Dr. Zhang mentioned earlier, randomized controlled trials are commonly considered the gold standard for evidence. However, RCTs may have false negative results where the results erroneously lead to conclusion that an intervention does not work any better than the control. As a simple example, the pregnancy test may be negative when in fact the patient is pregnant. An RCT may lead to a false negative result when there is not enough statistical power to detect a true difference. Think of a flashlight in the dark. Factors that can lead to this situation include participants withdrawing or lost to follow-up, patients not staying in their treatment group, such as active group or control group, measurements too not sensitive enough to detect differences, and tendency to give social desirable responses. Other reasons may involve the intervention itself, such as therapy error, dosing error, and effects of the placebo. Let's use acupuncture as an example. For therapy error, consider whether the study acupuncturist was well trained and experienced. Are we confident that the acupuncturist provide the correct Chinese medicine diagnosis to guide the appropriate treatment? When assessing for dose error, we will want to know the length of each treatment session, how often the patient received the treatment, and how many treatments they received to know if the acupuncture treatment dose was adequate. Sham acupuncture has been used as a placebo in studies. There are several ways to do sham acupuncture, such as inserting needles shallowly, inserting needles away from standard acupuncture points, avoiding needle stimulation and manipulation, or using a non-penetrating technique. However, some evidence indicates that sham acupuncture may still have real effects from needle insertion, and study participants may be able to distinguish when they are receiving sham treatment if they have had prior acupuncture experience. Most people have heard of the placebo effects when people feel better after receiving an insert of sham intervention. The reverse is called the nocebo effect, where people feel worse after receiving an insert or sham treatment due to psychological or psychosomatic factors, such as negative expectations or treatment prognosis. There is plenty of research about the placebo effect. However, the nocebo effect is still under investigation.
If you've ever watched the film The Matrix, the scene where Neo is offered a choice between taking a red pill or a blue pill instantly became meme-worthy in 1999. Taking the red pill meant learning the harsh truth of reality, while the blue pill represented maintenance of blissful ignorance. We've been conditioned to view the placebo effect as an undesirable blue pill that must be eliminated in research studies, as it reminds us that we could have accomplished something at a much cheaper cost, assuming you weren't getting scammed. But viewed from another angle, the existence of a placebo effect means your body has the innate ability to heal itself when given the right stimulus. From the point of view of pharmaceutical companies and device manufacturers, then, understanding the placebo effect is like taking the red pill. So it's all a matter of perspective and leads to some very thought-provoking observations about treatments in general. As a clinician, I've seen a number of patients with severely arthritic joints on x-rays who do not have any pain at all, whereas others with debilitating pain may only have mild degenerative changes on x-rays. Likewise, some patients experience significant relief for months after a steroid injection, while others feel little or no improvement. Why are their experiences so different when they all have a diagnosis of osteoarthritis? Studying placebo and nocebo effects can help provide greater understanding about the disease process. In a recent review article, Dieppe and colleagues described the placebo response as the ability of human interactions and contextual factors to activate our own self-healing response, and summarized what placebo and nocebo effects are most likely to change in osteoarthritis. So they're more likely to affect symptoms, such as change in pain severity or mood, physiology, such as the autonomic nervous system, health-related behaviors, such as self-management, and less likely to affect things like changes in pathophysiology in terms of joint inflammation or changes in joint structure. Of note, not all placebos are created equal. For example, intra-articular and topical sham therapies are often found to be superior to oral treatments in pain control. An intriguing 2014 study by Cam Hansen and colleagues revealed how both placebo and medication effects on pain can be modified by treatment expectations. They recruited 66 participants with migraines who recorded their pain scores 30 minutes and 2.5 hours into 7 separate migraine attacks. Participants bravely suffered through the first migraine attack without treatment for 2.5 hours in order to use the data as their individual baseline. For each of the other 6 migraine attacks, participants were asked to take a pill after recording their 30-minute pain score. 3 of the pills were placebo, and 3 were a triptan migraine medication known as Maxalt. Instead of keeping pills unlabeled, researchers assigned one of 3 labels to both placebo and triptan medications: placebo or Maxalt, or Maxalt. Results are summarized in the slide figures. The figure on the left shows percentage change in pain score from 30 minutes to 2.5 hours across the 6 possible label conditions. In the untreated attack, pain scores increased as expected, whereas pain scores generally decreased with any treatment, even when the placebo pill was labeled correctly. While the degree of change was greater for the triptan medication compared to placebo, 48% for Maxalt versus 21% for placebo, the effect of Maxalt mislabeled as placebo and that of placebo mislabeled as Maxalt were not significantly different from each other. The figure on the right side shows the percentage of participants who were pain-free after 2.5 hours. As expected, few, if any, participants were pain-free when their migraine attack was untreated. Overall, a quarter of participants who took Maxalt were pain-free after a migraine attack, compared to only 6% when they took placebo. However, Maxalt mislabeled as placebo was no better than placebo mislabeled as Maxalt. In addition, the effect of Maxalt was similar regardless of whether it was labeled clearly as Maxalt or if there was any uncertainty over the identity of the pill. So what does this study teach us? In an RCT, we're only using the unspecified labeling, which is placebo or Maxalt in this situation, and not completely capturing the full range of potential placebo and nocebo effects, such as when placebo is mislabeled as a medication and vice versa. However, the study also shows us that we don't always have to resort to deception. By using open-label placebos, we can still leverage some of the therapeutic effects associated with context and rituals around medication taking without deception. If sham surgeries can have stronger placebo effects than oral medications, what about sham surgeries? In 2015, Dr. Jonas and colleagues conducted a systematic review and meta-analysis of placebo-controlled randomized trials involving surgeries or other invasive procedures, such as endoscopic or percutaneous. Classical surgery was defined as procedures following a typical workflow of preoperative preparation, anesthesia, an incision through muscle and fascia and into the peritoneum, and post-op recovery. Surprisingly, the authors only found a total of 55 studies that met inclusion criteria for a systematic review, and only 39 that could be pulled into a meta-analysis. About half of the studies were pain-related. Back pain was most common, followed by arthritis, angina from coronary artery disease, abdominal pain, and endometriosis. Their results are summarized in the figure, with the black portion of each bar representing specific treatment effects that could be directly attributed to the actual procedure, and gray representing non-specific treatment effects from just undergoing an invasive procedure. The authors found that changes in the sham groups accounted for 78% of the overall improvement from treatments for pain-related conditions, and concluded that invasive procedures, such as radiofrequency nerve ablation, arthroscopic debridement, and vertebroplasty, were not clearly more effective than sham procedures for chronic pain. Since the study by Dr. Jonas and colleagues in 2015, Dr. Al-Lami and colleagues in the UK published the results of the ORBITA randomized trial in 2018. Previous trials showed that percutaneous revascularization, or PCI, where cardiologists open up narrowed heart arteries and put in stents to keep them open, does not reduce the rate of heart attack or death among patients with stable ischemic heart disease. PCI is still being performed, however, to relieve chest pain attributed to heart disease. So ORBITA compared the effectiveness of PCI for angina-type chest pain versus a sham procedure among 200 patients who were medically optimized for single-vessel severe coronary artery disease. Although PCI did improve heart wall motion abnormalities on stress testing, no difference was found in the primary outcome of treadmill exercise time when compared to sham. The authors also looked at the effects of PCI on symptoms such as physical limitation and angina frequency and stability using the Seattle Angina Questionnaire. They also looked at quality of life using the EuroQual 5 Dimensions Questionnaire, which covers mobility, self-care, usual activities, pain or discomfort, anxiety or depression. Again, no difference from sham. Surprisingly, this was the first placebo-controlled randomized trial for a common cardiac procedure that's being done over 500,000 times a year worldwide, which makes you want to question every procedure that was never tested against a sham procedure. As the authors note, we can never forget the complex relationship between anatomy, physiology, and symptoms.
Dr. Zhang briefly discussed the concept of different levels of evidence. For example, a well-done systematic review of 2 or more RCTs is better than 1 RCT. However, RCTs are just one source of evidence. Let's talk about how we can draw upon many different types of evidence to figure out whether a specific therapy works. As you can see in this diagram, there are many different ways to evaluate clinical therapies. Each type of evidence has its own strengths and weakness, and it may take different types of studies to get a full view of a particular therapy. Some important considerations are methodological quality, clinical rather than just statistical meaningfulness, and relevance to real-world practice. For each type of evidence, there are standardized criteria and checklists to help evaluate the quality of studies. You can check out the Equator Network website for examples. One important question is, does the best evidence equal best therapy? That is only valid if the following conditions are met. First,
You know what? We can also just pause and you can re-record that part again.
maybe we from this here.
Yeah. Just record from here.
From here.
Yeah,
How
so
to
let's
how
pause.
to how to
Equator.
equator.
Okay, let's pause.
Okay, so I just start from here.
Yeah.
Okay. Just start. Okay, as you can see in this diagram, there are many different ways to evaluate clinical therapies. Each type of evidence has its own strengths and weakness, and it may take different types of studies to get a full view of a particular therapy. Some important considerations are methodologic quality, clinical rather than just statistical meaningfulness, and relevance to real-world practice. For each type of evidence, there are standardized criteria and checklists to help evaluate the quality of a study, or you can check out the Equator Network website for examples. One important question is, does the best evidence equal best therapy? This is only valid if the following conditions are met. First, conducting an RCT is equally feasible for all potential therapies. Second, RCTs are conducted under conditions similar to real-world clinical practice. Third, RCT results are free from confounding factors. But these three conditions are rarely met. Integrative medicine clinicians strive to provide appropriate individualized, cultural appropriate, and patient-centered care rather than providing care for an average patient. Therefore, to ensure optimal patient care, we should evaluate the existing evidence in the context of our own personal experience, internal knowledge such as local performance data or evaluations, professional knowledge, and patient perspective. Dr. Kakihui, the director of the UCLA Center for East-West Medicine, gave a lecture in 2016 about innovations in healthcare research design for the UCLA Clinical and Translational Science Institute. He stated the need for innovative methods in traditional trans medicine and integrative medicine research mirrors the needs for similar methodological transformation in medicine more broadly, especially with the rapid increase of chronic health conditions and the realization of the limitations of the RCT. In the following 15-minute video clip, he describes examples of innovative methodologies in integrative medicine research.
We wrote a paper about building evidence base for TCM and integrative medicine. And I think we'll go over this a little bit and give some examples. Each of these approaches expands upon conventional approach to clinical research and can be combined with clinical trial data to yield a mixed methods approach. So obviously, patient-centered outcomes research. It's been, like, I don't know, 6-7 years, and it's still, sort of slowly moving into, the realm of thinking of many of the researchers. But again, I wrote a paper with Marian Katz and also Sonia Priska about the whole idea of patient-centered medicine, the difference between East and West, and how we actually use both at the same time in our clinical approach. Then I think that over the years, there has been comparative effectiveness research. The drug company has always been blocking over years comparing two different drugs, okay? Because it's easier to demonstrate it's better than placebo. But once you compare the two, and if one is not as good, it will drop off from the formulary. So, but in clinical pharmacology, we have been pushing for comparative effectiveness research for like 20-some years. So the other approach is whole systems research. And that's what I talk about, is that, they come to our black box, they come to our clinic, and then it's a black box. They think about acupuncture just as, one component, okay? But realistically, there are many things going on in that clinic, that visit. So you have to think about the whole systems research approach. And again, health service research is also very important. It's been ongoing for like 40-some years. Before I decided to go to do clinical pharmacology fellowship and go with the biological route, I almost became a health service researcher. But I think that this is a very important field of research that now demonstrates a lot of problems. But we need to figure out how to do the research to show how you can solve problems. I think qualitative research is also very, very important. We clinometrics. I mean, I still remember, the Yale, professor. His name just, escaped my slowly declining brain. But, we lost a lot of data, by not knowing the person, by not knowing more about the person. So So you need to look at qualitative research and combine quantitative and qualitative together and get mixed methods research. So, so basically, patient-centered outcomes research helps people and the caregivers communicate and make informed health decisions, inclusive of the patient preferences, autonomy, needs. Those are outcomes that people notice and care about: survival, function, symptoms, and health-related quality of life. Incorporates in a wide variety of settings and diversity of participants to address individual differences and barrier to implementation and dissemination. Difficult, but very, very exciting, but still developing. And that, and I think that I think it's important for CAM research, and I'm glad that Helen, that you are working on a grant, for PCORI, right?
PCORI, yeah.
But I think it's sort of important to kind of look at many of the components of the research questions. So current studies supported by PCORI, in the area of acupuncture approaches to decrease disparities in outcomes of pain treatment, a two-arm comparative effectiveness trial, optimizing patient engagement in a novel pain management initiative, and then choosing options for insomnia in cancer effectively, comparative effectiveness trial of acupuncture and cognitive behavioral therapy. So what are the advantages of comparative effectiveness research? I think the advantage is that it's easier to recruit people and retain people. It allows us to kind of look at individual responses and preferences rather than general outcomes, and focusing on connecting research results to patient needs, and avoid challenges associated with developing appropriate control interventions, because sometimes it's not easy to control, and also challenges with blinding, and also people know that they are getting a good faith treatment. And the challenges are listed, and I don't want to kind of read through it, but you can obviously, as you embark on this type of research, you know that it's every new approach, and that's the reason why people are not doing it. Is every new approach, can be quite messy and difficult, and may not be accepted by the journals, that may still have concerns about some of these approaches, because anything new, some people may not want to accept it. It takes at least 2-3 decades, and so we think that and Claudia Witt, she used to be in Germany and now she's in Switzerland. She's a major researcher in Europe on looking at acupuncture, and that's sort of some of the things that she really talk about, using trials that compare acupuncture plus conventional care to conventional care alone was closer to effectiveness than those that perform on a head-to-head comparison of acupuncture and conventional care. And I think this is sort of what I think would be easier for people to accept. So whole systems research. Iris Bell in Arizona, I think, again, a major thinker in research in this area, look at whole systems. And I believe that well-designed observational trials, which permit assessment of the patient in his or her full real-world environment context, for us would be very, very important. And that people need to know that RCT are only one tool among many in the pragmatic whole systems research, including pragmatic trials, factorial designs, preference trials, and N of 1 trials. I remember 21 years ago, we already talked about this in terms of herbal research. But again, it takes a lot longer time for things to happen. So the challenge for whole systems research is need to identify appropriate valid outcomes, reduce ability to control the effects of non-specific components of the treatment, and methodological challenges such as inter-rater reliability for diagnosis, different treatment styles, and also complex statistics often required. So a study was published in 2008 on whole system clinical trial of translational Chinese medicine, traditional Chinese medicine, and natural medicine for treatment of TMD. And it's a small study, and that there's a positive results. But again, as we mentioned earlier, we need to look at inter-rater reliability for TCM diagnosis, as well as determining best outcome measures. So, yeah, this is a study that we did, kind of close to a whole systems research, because people come to us, it's not just getting acupuncture. They are also getting educated about acupressure at home, how to handle stress, how to eat, how to, to deal with cancer-related fatigue. Some of these patients have pain as well. And when we first tried to get IRB approval, they fought us all the way for a year before they allow us to do this trial. And we just say, okay, we just say patient education. And but basically, it's closer to what is actually happening clinically by adding education with acupuncture, and that we demonstrate that it's very, very useful. And then subsequently, a trial was done to show that acupuncture was very useful for cancer-related fatigue. And then I wrote an editorial about that multi-center trial. Well, health service research, I mentioned earlier about why this is important, and that I was very, very interested this past Saturday listening to Dr. Holmes' work on value-based research, and how he applied to inflammatory bowel disease, and looking at different components from biologic biomarkers to disease activity to educating the patients and to including wellness in the component. It's really so it's. I think the reason why there's a movement towards a lot of this type of research is because now as we move to an ACO, and when the income is less than the expenditure for managing a particular disease, we need to figure out how to incorporate some of the approaches that may be as effective and maybe safer. When you're safer, you save money. And I think the key thing right now is that in this type of research is going to be much, much more important after 40-some years. Is because I think the time is for clinical care delivery. With pain, even pain. I mean, right now, there's so many patients that we see. We have a component to take care of people who cannot get out of the hospital when they have pain or nausea and vomiting. They keep going in and out, and that every 30 days you go in, you have to pay a penalty. So I think that health service research, is going to be very, very important. And these are some examples of using this approach. But again, not a whole lot, not enough. We did a study with Ron Hayes looking at statistical significance of health-related quality of life change in individual patients, and looking at changes in this for 54 patients through our clinic. This is a study. It's published in you can read more closer to an evaluation of health profession. So I talk about qualitative research because I really think that most people, most patients basically have a story to tell. And I think in general, a lot of things have impact on people's thinking because people share the stories. And I think that this is a part that I think will be becoming important as we bring the person back into the research arena, and that so I think and that we also sort of publish Priska, our this issue left recently for a new job elsewhere. And the mixed methods basically combining the quantitative with the qualitative research, and that I think it will be important to include this in some of the newer approach of research.
Okay, I know that was a lot of information. So to recap, Dr. Huey's lecture covered 5 methodologies that can be applied to integrative medicine research, which I'll translate into layman's terms here. Patient-centered outcomes research focuses on the question, does it address what matters to patients? Comparative effectiveness research seeks to answer the question, does it work better than existing treatments? Whole systems research is interested in, does it work as practiced in the real world? Health services research wants to answer the question, is it accessible, and did we get what we paid for? Qualitative and mixed methods research can help you find out the answer to why or why not.
Many holistic, traditional, complementary, alternative, and integrated medicine systems rely on complex conceptual models and diagnostic approaches different from or in addition to biomedical science. Here we have some examples for the characteristics of clinical whole system models. This table is from Dr. John Weiss, the editor-in-chief of the Journal of Alternative and Complementary Medicine. His team published a review paper in 2019 about whole system research methods in healthcare. There were 41 clinical research papers were selected for review from 13 traditional complementary and integrated medicine disciplines, with the aim of mapping the range and methodological characteristics of whole system research studies. Let's look at the section on traditional Chinese medicine, chiropractic medicine, and integrated medicine as an example. The first column lists the paradigm of interest. The second column briefly describes the conceptual model. The third column lists diagnostic technique used, and the fourth column lists major treatment modes. If you are interested in conducting a whole system research starting from a specific paradigm, such as Ayurvedic medicine, homeopathic medicine, yoga, or anthroposophic medicine, I recommend that you read this paper for further details. Most studies on complementary and integrated medicine interventions include routine or usual biomedical care combined with at least one additional whole system paradigm. The figure on the left shows typical features of interventions in whole system research. As you can see, the interventions are typically complex, individualized, address more than one diagnosis, and involve behavioral components, such as diet, exercise, stress management, mind-body practice. About half of the studies implement dual diagnosis, where patients are diagnosed from both a biomedical perspective and from the perspective of another paradigm such as traditional Chinese medicine. Interventions may also be multidisciplinary, involving practitioners from more than one discipline to deliver their care. The figure on the right shows typical outcomes that are assessed. As you can see, the vast majority of studies use pre and post measurements to evaluate treatment's impact and include subjective primary outcomes such as symptoms severity scales or validated patient-report outcomes measurement, measuring quality of life, wellness-related scores, treatment expectation, and treatment satisfaction. Most studies also monitor for adverse events, which may include lab samples or self-report. As we will discuss later, qualitative methods are not used as much as they could be, and economic evaluations are even less utilized. With regards to patient-centered outcome research, what matters most to patients? What benefits do patients gain from complementary medicine modalities? In a 2012 U.S. survey of adults with gastrointestinal conditions, the top three perceived benefits were improved overall health and feeling better, have a sense of control over one's health, and better coping with health problems. Other benefits included reduced stress, better mood, better sleep, improved relationship, and improved attendance. Ultimately, patients want to have better quality of life, not just live longer. I would like to talk a little more about qualitative research, as people are generally not as familiar with these types of studies. Qualitative research is a scientific method of observation to gather non-numerical data. These types of research refers to the meanings, concepts, definitions, characteristics, symbols, and description of things or events, and not to their counts or measures. Quantitative research is the systematic, empirical investigation of observable phenomena by statistical, mathematical, or computational techniques. This slide shows a simplified comparison of qualitative and quantitative approach to research. Some researchers combine qualitative and quantitative methods in a single study. These studies are called mixed methods. The choice of whether we use a quantitative, quantitative, or mixed approach depends on the research questions that we are interested in. In 2013, a systematic review investigated how often qualitative, quantitative, or mixed methods were being used in complementary and alternative medicine research. The author screens all studies published in the top 10 integrative and complementary medicine journals in 2012 and include 2,349 papers. Quantitative studies dominate the top 10 CAM journals, representing 84% of all published papers. Only 4% of papers reported mixed method studies, and just 1% reported studies using qualitative methods alone. The other 11% of papers did not report primary research. This included protocols, reviews, and theoretical pieces. Based on this study, qualitative methodologies may be underutilized in integrative medicine research.
Let's summarize what we've learned in this module. Research on complementary health approaches is growing rapidly and spans basic science, translational, efficacy, and outcomes and effectiveness studies. Qualitative and mixed methods are underutilized. They can provide insight into local and contextual factors, as well as deeper understanding of observed phenomena. Four innovations in healthcare research designs have been successfully applied to integrative medicine: patient-centered outcomes research, comparative effectiveness, whole systems research, and health services research. Factors that may lead to false negative results in randomized controlled trials include therapy errors, dosing errors, an active placebo, or insufficient sensitivity of measurement tools. Research is revealing the role of placebo effect in procedures and surgeries for pain management and how an appropriate stimulus can stimulate or trigger the body to heal itself. If you would like to read the articles cited in this module, we've listed them on the following slide. Thank you again for joining us.